Thank you all for joining us today, either here in the room or via Zoom. I am Phaedra Charlton. I am the Director of Communications and Marketing for the World Ovarian Cancer Coalition. Just a few housekeeping items before we begin. Our press kit for this briefing is available electronically and is accessible via the QR code that is on by your chairs or on the screen here. And a link will also be emailed to you after the event. We're asking that everyone save their questions for the end, where we have set aside 15 to 20 minutes for a Q&A. And we are pleased to have several members of the Every Woman Study team here today. For those of you joining online, you can submit your questions via the Q&A box at the bottom of your screen. So now it is my pleasure to introduce Claire Mckay, CEO of the World Ovarian Cancer Coalition.
Thank you, Phaedra, and thank you all for joining us today, as Phaedra said, virtually and in person. It's just a delight to see you all. I am Clara. I'm CEO of the World Ovarian Cancer Coalition. We're a network of close to 200 patient advocacy organizations from all around the world, and we all share a commitment to ensuring that every woman diagnosed with ovarian cancer has the best chance of survival and the best quality of life possible wherever she may live. So ovarian cancer remains one of the most lethal of women's cancers. In higher income countries, 5-year survival rates range between 36 and 46%. But we know in lower income countries, this figure is much, much lower. As you will have seen in your background materials, the number of new cases globally of ovarian cancer will rise by 42% by 2040. Even more shockingly, deaths will jump by over 50%. So if we do change the status quo over the next 18 years, over 4 million women worldwide will die from this disease. This is a pressing public health concern that requires urgent global action. However, it is especially significant that over 70% of women who are diagnosed with ovarian cancer live in low and middle income countries. This is where the burden is heaviest, and this is where the loss will be greatest felt. Our Access to Medicine report released today highlights many of the specific challenges that low and middle income countries face, including lack of access to data to support effective cancer control planning, fragile healthcare systems where often even the most basic treatments are not readily available. And when they are, these treatments are available, many women will face paying for them out of pocket, resulting in financial catastrophe, or actually more likely just not receiving any treatment at all. But beyond healthcare systems, women in low and middle income countries routinely face other significant barriers to accessing treatment, including not able to access or afford transport to hospitals, even when those treatments may be free at that hospital site. So the purpose of the Every Woman study is to provide much needed evidence on the experiences of women with ovarian cancer and the healthcare professionals that are dedicated to offering the best possible care in these settings. This data is vital if we are to influence national and global policymakers to take action to improve care and outcomes. I'd like to say a few words now about our partnership with Igcs. We are really proud to work with the International Gynecologic Cancer Society, and partly that is because of the concept of health equity that is so embedded in the core of their work. And we are just delighted to be working with them as partners on the ovarian cancer, on the Every Woman study, and share the priorities that we both feel very strongly about. The Every Woman study and the process by which we are implementing that study with IGCS will lay a strong foundation for stronger ties between clinicians and patients, who together we know can be a commanding force for change. It is our hope that this study will not only benefit women with ovarian cancer, but it will also act as an excellent example of good practice for other patient experience research in all disease areas. With that, I'm really delighted to introduce our Director of Programs, Frances Reed, who will take us through a presentation on the Every Woman study. Thank you so much.
Thank you. The Every Woman Study Low and Middle Income Edition is based on the Coalition's original Every Woman Study from 2018. 1,531 women from 44 countries took part in an online survey in 15 languages, and the results were published in the International Journal of Gynecological Cancer in 2020. We came up with a set of issues that were prevalent everywhere, from awareness of ovarian cancer as a disease and its symptoms, delays in diagnosis, access to the right treatments and surgery, a lack of action over family history, lack of information and support, and inadequate data. But the extent to which these issues were a problem in different countries varied, and that's the key to this study. I'll give you a quick example here. We've got the United States, Japan, and the UK. So women and women's knowledge of ovarian cancer was pretty good actually in the United States and good in the UK. However, time to going to visit a doctor was varied, and in the States in particular, that was quite slow. This contrasted with Japan, where women didn't actually know much about ovarian cancer, but when they felt unwell, they went to their doctor quickly. In Japan, the doctor then did something about it very quickly. That contrasted with both the United States and in particular the United Kingdom. So much so that the average time to diagnosis from symptoms occurring was different by about 3 to 4 months, with Japan being ahead. So really significant delay in diagnosis. We also looked at measures relating to access to specialist treatment, access to genetic testing, which was very poor in Japan, very good in the States, information and support, and another number of other issues. So it's the difference that's important. We can learn from each other. These were the countries that took part, and you can see that most of them are high-income countries. And in actual fact, 95% of survey respondents came from high-income countries. This contrasts with the fact that only 30% of women live in these settings who have ovarian cancer. So 70% of women with ovarian cancer live in low or middle-income countries, and we have no data on that. So it's an important data gap to be filled. The reason it's important is because of the projected increases in incidence and mortality to the year 2040 by Globocan, predicting 36.6% increase in incidence and nearly 50% increase in mortality. And when you look at which areas are going to be hit the hardest, you will see it is developing countries. So Africa should expect to see an 86.9% increase in incidence. So even if it's not obvious that ovarian cancer is a major issue, it's a challenging disease to diagnose and treat, even in high-income countries, this will get a lot worse for countries such as those in Africa, Latin America and the Caribbean and so on. So it's a really important time to take stock of what is happening and what can be done. So our objective is to address that patient evidence gap and to identify the opportunities and challenges to overcome the challenges and improve quality of life and survival. Our intended outcomes are that we not only have a global data set, but that we have national and regional data that is relevant and usable on a range of key patient experience issues, and that this will drive advocacy and system change. We hope to have many publications from the study, not only at an international level, but at a national level, with those teams leading the way. And we'll be able to provide comparability between other low and middle income countries at national and regional levels. We also hope that it will help foster a relationship between some women who have ovarian cancer and their clinicians to build advocacy work, to foster new or develop existing relationships with NGOs to drive forward change, really developing a collaborative voice. And will make the study more widely available to others after this study period. We have 24 countries signed up to the study in slightly differing stages of development and preparation, but you'll see there's a good mix between upper middle, lower middle and low income countries, and a good geographic mix. We expect a data set of more than 2,000. Each country can have up to 10 clinical centres participating, but this really does vary by country. So for example, in Zambia, they just have one cancer centre, that is it. In other countries such as Nigeria, Kazakhstan, Argentina, there are many more participating. So it really does vary by country. The survey is available in 31 languages, and we've worked really hard to make it as accessible to women as possible through multiple translations, through the fact that women can access it via secure email or WhatsApp link, or they can do the survey on paper in the clinic, or they can have somebody sit and go through the survey with them in the clinic if they don't have the literacy skills or would prefer somebody to work with them. Our clinicians involved in the study are doing an amazing job. They'll be providing detail for each patient on the type and stage of ovarian cancer, details of drugs used and surgery undertaken, and genetic testing. And our country lead clinicians are doing video interviews and will take part in an in-depth survey on the state of ovarian cancer care in their country. And this will provide really important context. So where are we now? Well, we have 5 countries collecting, others about to start. Malaysia was first off, followed by Brazil, and Kenya, Jamaica and Argentina have very recently started collecting data. So far, 96 women assessed, of whom 86 are eligible, and data has been collected so far on 72. And we have a live data capture system, so we can report some key stats as they come through. So at the moment, we've had participants aged from 18 to 78, the average age about 53 years, if you take the median. 2/3 of the women who have ovarian cancer in this study so far are employed, and the majority of those, by far the majority, are full-time employed. And there's a good spread of income between average, above average and below average for their country. And unsurprisingly, high-grade serous is the most common form of the disease, and endometrioid is the next most common. And we have a range of stage on diagnosis. So it's really good to get this sort of live data. It gives a sort of good feeling of the study in progress. Data collection we expect to continue till June 2023. There have been lots of challenges getting this underway, trying to make sure the centres reflect care in that country, making sure women can participate, ensuring those with the least resource can participate, and that has included providing some extra funding for research where there is literally only one centre participating with a clinician who's not even a gynae oncologist. We've also covered core expenses such as translation and ethics submissions and provided honorariums to take part. It's taking time to get things off the ground. We have 125 sites. Many require local ethics approval as well as national ethics approvals. We've had emigration of key personnel or illness. We've even had local unrest delay things where staff had to go into hiding. And of course, the impact of COVID has provided challenges as well. But it's really important to get this data because in the middle here of this diagram, you've got access to diagnostics, surgery and medicines, and those are not a given in LMIC countries. But even if they were, there are then financial, geographic and cultural barriers and issues around health literacy. Capturing all of this is really important because for each woman in whatever setting she is in, there will be different routes and different barriers to her being able to get the right care and treatment. And understanding the challenges in a local environment is really key to making progress. We've had some good early outcomes, new patient information, a new ovarian cancer support group, and we've had clinicians engaging with national advocacy groups on matters such as access to treatments. So we're really thrilled already with what's been happening. But none of this would have happened without our brilliant oversight committee and set of country leads, and there's some overlap between the two. They worked really hard to make the study relevant, to provide insight and expertise in how we can make this happen. And I hope particularly for the country leads that what they will get out of this study will be the start of some really important work. And I would really like to thank them on behalf of the coalition and IGCS. Thank you very much. And now I'll hand back over to Robin Cohen, who is actually Vice Chair of our Oversight Committee.
Hello, it is my pleasure to join you here this morning, both as the co-chair of the coalition, or the vice chair of the coalition, and the co-chair of the Oversight Committee for the Every Woman Study Low to Middle Income Edition. Conducting a study on this scale is complex and not without its challenges, but is often the work that is the most challenging, that is the work that is most needed. Frances has provided an excellent overview of the study. We are delighted that data collection has started in several locations already. Throughout the process of this study, we have been amazed at the enthusiasm and of dedication of not only the patient advocates, but of the clinicians who are involved, even in the face of extremely limited resources and the ongoing COVID-19 pandemic. As part of the Every Woman study, we have interviewed lead clinicians in participating countries. First, to get their perspective, but also to capture what we can of the missing women. Today, we wanted to share with you our experiences from some of these clinicians and advocates to help provide further insight into the challenges that they and the women they care for face.
Thank you, Robin. It's my honor to be part of this outstanding project. I am Florence Anol. I am a gynecologist. I'm a member of the Oversight Committee of the Every Woman Study, Low and Middle Income Edition. And also I'm the country leader of the project from Argentina, the second largest country in South America. First, I would like to highlight that we are working as a team with the 10 referral centers in my country, and I'm proud of it, but it's a large country, and you know that's a complex job. So the national inequality is a big challenge, reaching out all our patients and even our clinicians. We have no centralized care and no proper surgical training. Nowadays, big distances, poor communication, and the lack of a proper training are a setback. Regarding patients from not being able to reach the hospital due to transportation issues to the economic impossibility to afford surgical or chemotherapy treatments, they have limited or even non-existent access to diagnosis, treatment, and care in my setting. In the other hand, about clinicians, I think that our mission is focused on coordinating efforts and raising awareness among our colleagues, among us, about the necessity of quantifying the experience of all women from such different realities living in the same country. This is in order to foster our net, which I think is the most important tool for improving our performance and strategies for patient care. From another point of view, me as a clinician, I've gained experience and understanding through the patients themselves, speaking about the impact of the disease in their quality of lives, and their very limited access to information about their illness. And I've also learned through my colleagues, through their realities and their effort in daily practice. Teamwork now is proving to be a very challenging task, a very big task, and the Every Woman study is the first study in our region connecting clinicians and women with ovarian cancer all over the country. Also, it is helping us to improve and foster our communication, because in our field, as in many others, change can only happen when it is based on evidence. In this line, reaching women experiences as they move from pre-diagnosis to post-treatment and the quality of life throughout will serve as a guide to identify particular local challenges and develop regional and local strategies for authentic and constructive solutions. On the other hand, creating a national database, a cancer registry, is something that we're lacking of, will be a cornerstone for further regional research projects that will probably support new and more advanced public health policies. Speaking about the hopes for our women, I think that achieving this goal will be the key to closing the wide gap in care, equity, and inclusiveness for those bearing the heaviest burden of the disease. Only when we quantify the experiences of those women living in underserved settings shall we be able to see the way forward for change. Our goal is to improve early access to health system, to decrease the waiting time to get to the specialist, and also to provide continuous and better support, standing by the patients throughout the whole path of the illness. This is a groundbreaking study, and it will give voice to the problems and opportunities of the women themselves. In a way, they are the ones that will help create this change in their lives.
Often physicians are seen in a purely clinical light, and we forget that there is a human being behind the stethoscope who wants better for their patients. Renee Perea is one such doctor who will tell you about the personal price he pays for caring for women with ovarian cancer in Colombia.
My name is Rene Pareja. I'm a gynecologic oncologist. Around 20 years ago in Colombia, I was formed at the Instituto Nacional de Cancerología in Bogotá, but my workplace is located in Medellin, Colombia. I work in two private institutions working for the public health system, as usually happens in my country. The private institutions usually work for the public health system. Eventually, I became friend from several of them. They're friends. They're my friends. We go to their houses. They came to here. Depends of the type of relationship that you can establish. It's more easy if the patients, there is a, I don't know how to explain this well. It's a kind of click. You may click with some kind of patients, and those who respond well to believe in the treatment, to trust in the doctor recommendations, they'll go well. And of course, I have lost most of them. I remember them by their name. I visited them in their houses. Right. I have accompanied them at the end of life, most of them. In some cases, I still have the contact in my WhatsApp with their husbands, and I used to talk with their husband. They, in the day of the doctor, they send messages to me, their congratulations, kind of things like that. But those are the most difficult patients, because when you are seeing the patient by first time, you have those lady has a 75% chance of dying of the disease, but she doesn't know that. The family doesn't know that. Nobody doesn't know that I really know. And this is sad. This is sad, because at the end, the statistic is the same. You lost 3 or 4. And this is a hard way to walk on. It's a hard way as a patient and as a doctor.
Unfortunately for many, getting to that first meeting or any meeting with a doctor is an insurmountable challenge. Nayaka explains how geography is sometimes the greatest barrier to access and how some of those challenges might be overcome.
My name is Ngọc Phan. I'm a GYN oncologist in Vietnam. I graduated from OB/GYN residency in 2014. In my practice, I saw a lot of patients who come from remote areas. They are very poor and they don't have enough condition to access the internet, the information, as well as the transportation there is quite difficult to them. And that's why they usually come to us with very advanced symptoms. And many cases are that they lost to follow up. It's painful that we can cure their disease, but we cannot cure their surveillance. They, after surgery or after one course of chemotherapy treatment, they gave up and lots of follow-up. That's very difficult to treat those situations because they are living in remote areas and they have their languages. I and my colleagues, we are trying to learn their language to have a better communication with them. Our goal is no one left behind. In our institute, we have a online appointment. So the patient during the pandemic, the patient should learn how to access the internet, so they can easier to choose a day with their clinicians as well as the day they receive their treatment. So it's more convenient. And telephone appointment, yes, they can call their service health services to receive recommendations as well as their information.
Even after getting to that meeting and getting a diagnosis, the availability of information and support to women and their families can be poor or non-existent. Instead of spending time together, loved ones are forced to spend their time searching for information on treatments, compounded by the burden of having to pay out of pocket for treatments available in many other countries. Rafael Sadnan Adel contributed to our Access to Essential Medicines Report, and Every Woman Study Oversight Committee member explains.
I'm Rafi Sadnan Adel. I'm the head of media and external relations here in the world's largest non-profit organizations titled BRAC. And in person, I'm a former journalist as well. And in Bangladesh, I am the founder chairperson of CancerBD.net, which is the first ever cancer awareness web portal, which is totally narrated in our native language, Bengali. And I would like to share a few experiences with you all so that you can easily connect why CancerBD.net is important here in Bangladesh. Back in 2010, my mother was first diagnosed with ovarian cancer, and she has suffered around 3.5 years in this type of cancer. But unfortunately, we lose her in 2014, 31st May. In this journey, I have suffered a lot in terms of informations, in terms of financial capabilities, because here, that time Bangladesh is a lower income country. Right now it's a mid-income country, but that time a person from a middle income country has to struggle a lot for this sort of treatment, because as you all know, the chemotherapy drugs are very expensive here in Bangladesh, as well in South Asia. And apart from that, I have suffered a lot in getting information, because all the informations are based on the West countries and in English as well. So to connect, to know more about cancer was a very tough task for me for the first time as well. So I have got an idea that we need to have platform where we will get more informations about cancer, and most importantly that informations should be in Bengali. Then in 2014 we have started cancerbeti.net, which is a Bengali language cancer awareness site, and we have tried our best to get authentic informations from the other English based websites, and we just translated those and get cross-checked by the current physicians, oncologists, and put that into our website. That was our first journey. And after passing 2 or 4 years, we get to know that it's in Bangladesh, the social media platforms are getting very powerful. Even the government counted these platforms with a very high value, and all around the peoples are browsing all the informations and through the social media, and they got hugely involved in these areas like Facebook, Twitter, YouTube. Then we have started using these sort of platforms to disseminate our informations, cancer awareness informations there. And this year, after the 8 years journey, we have taken a 5 years plan, and we have changed a little bit our slogans. Right now, our slogans is we prevent cancer through communications, because we do strongly believe that the countries like us, the countries of South Asian countries, need to focus on one thing, that is early detection, because only early detection can save us from the higher expenditure of treatment in cancer. So we are focusing on early detection through all the communications channels by our initiative cancerbeti.net.
But even when women can get to the doctor or their hospital and find the information they need, other challenges remain, as Dr. Pariyar from Nepal explains.
I'm Jitendra Pariyar. I'm a gyne-oncologist serving in Civil Service Hospital, and I'm also attached to National Academy of Medical Sciences, which runs post-graduation and fellowship program, and I'm the professor in Obs-Gyne, taking care of gyne-oncology as well. And I'm the mentor for International Gyne Cancer Society fellowship program Nepal site. So as per my work, I'm based in Kathmandu, which is the capital city of Nepal. And I'm a clinician and academician. And as a professional, I spend around 70% of my time catering most of my services to cancer patients, apart from general hospital services. So since we had the diagnosis, we wanted to give chemotherapy, but somehow patient party, especially the husband, wanted alternative medicine. We knew that this was a chemosensitive tumor, but they heard about alternative medicine, herbal medicines, which they thought was better than chemotherapy, because chemotherapy, they had seen some of our patients with alopecia and weakness, so they refused chemotherapy. And this was such a sad case that we, like all of our team members, felt from gyne-oncology, from clinical oncology, we knew that she would do well with chemotherapy, because germ cell ovarian tumor being very chemosensitive, and she was young. But the patient and her family denied chemotherapy. Hearing and seeing that the chemotherapy was associated with some of the side effects. So this was a very sad case, and we kind of lost her. We have not met her.
But there is hope.
The Every Woman study is already inspiring change and opening doors to new possibilities, from the first ever ovarian cancer patient group in Malaysia, local advocates successfully working with the National Health Ministry in Malawi, to energizing Aisha Mustafa, our lead clinician in Nigeria.
My name is Aisha Mustafa. I'm a medical doctor, a consultant obstetrician and gynecologist, specifically working in the gynecologic oncology unit at Ahmadu Bello University Teaching Hospital in Zaria, Kaduna State, northwestern Nigeria. I basically work in gyne oncology, and I see only gyne oncology patients. And I'm actually the country lead for the Every Woman study in Nigeria, and I'm super excited participating in the Every Woman study for low and middle income countries. The Every Woman study for me, being on the team, is actually, shall I say, I feel honored to be part of the study. And why I'm actually excited is because this is the first time we in Nigeria are conducting a multi-center, specifically a 12-site study, prospectively recruiting women with ovarian cancers in the 6 geopolitical zones of the country. And with this will help us actually identify the key challenges these women are facing and actually document them, because some of us know the challenges, but these have not been documented in such large scale. And apart from identifying these challenges, it will also help us to provide the opportunities on how we can improve the overall survival of these women by actually getting policy statements from such research. That's for us generally. Then to me personally, I'm actually excited participating in this study because it is actually improving my own capabilities in research. I have not participated in such study before, and I am seeing how this is going on from the beginning through when we started almost a year ago. And it has actually opened my mind to future possibilities, future collaborative researches among the members of the 12 sites participating sites, and also the international community, and even beyond. So this is actually helping my own research capability. And I also see us collaborating for the future after providing a database for ovarian cancer patients. And of course, with their permission, we'll be able to call them up and probably do even more research based on the number, on the women that we have recruited for this study. I actually believe that this study will change the future for ovarian cancer care in Nigerian women, and also for us, the researchers that are participating in it.
That's incredible. As you've learned here this morning, even though we have just begun to capture the stories of women with ovarian cancer in low and middle income countries, a compelling prologue is emerging for the narrative. The Access to Essential Medicines Report outlines some of the challenges in low and middle income countries with the unavailability of effective and inexpensive workhorse medications, leading to needless suffering. A paucity of data impedes advocates who need evidence-based solutions to be the most effective, and governments have little basis from which to create national cancer control plans. We anticipate the final Every Woman study report will echo many of the challenges and issues revealed here this morning. There is so much more to learn from the women themselves about their specific circumstances and barriers, because only they can fully tell their story and tell us where we would be most impactful advocating for change. While we look forward to the results so we can work on a global level, we are excited that the data will be robust enough so each country will be empowered to navigate the path to change themselves, to improve the experiences of their mothers, sisters, wives, friends, and colleagues in their own communities, working together at every level so that no woman, no matter where she lives, is left behind. I'm now going to turn it over to Phaedra and we'll open it up to questions.
Thank you so much, Robin. And actually, I'd love to invite Mary Eichen, CEO of IGCS, to come up and just say a word or two about the partnership. So Mary, if you could.
Good morning. Thank you. I apologize. I was a little bit late today. Went to the wrong hotel. So that's one way to start your week of meetings off, isn't it? Well, thanks again for having us, for allowing IGCS to be a part of such an important study for women. The IGCS is committed through our global health equity statement of addressing issues just like what this study will do for us. It's so important that we address areas in low to middle income places in the world. We help them find solutions and deliver on our promise to make things better for them and all women with gynecologic cancers. I'm so pleased today to have some of the steering committee here with us as we kick off our meeting here in New York. Later today, through our partnership, the World Ovarian Cancer Coalition will be presenting some of this information to our patients who are coming to a patient summit for them and their caregivers later this morning and into this afternoon. So it's really exciting to have the WOCC here in New York with us. Partnership along the way, side by side, and today explaining more about the study to women at our patient summit. So thanks again for having us. Amazing organized effort here by the WOCC team, as always. And I'll give it back to you, Phaedra.
Great, thank you so much, Mary. And we did have a question coming on WhatsApp for our team from Kazakhstan. So if you wanted to come up, it's a quick question, just talk to some of the, we had videos explaining some of the cultural barriers in some of the other countries. And we just, question came in asking about what cultural barriers may exist in Kazakhstan for women accessing ovarian cancer treatment and care. So I'll invite, is it Raikhan or Diara? You can both come up. There's plenty of room on screen for both of you. We're so pleased to have our, as Mary said, some of the members of the oversight committee here and country leads. And I think the camera's just like that. So yeah, I was just asking about the cultural barriers in Kazakhstan.
Thank you for all. And we're very honored to be a part of this study. For our country, it is very important. And because every year we detected more than 1,000 new cases. And 80% of the cases is advanced, of course. And of course, we have problem. Our country have huge territory, and that is why a woman, she have a family, she have many children, and she haven't time to go to doctors. And this is one of the huge barriers for us. And it is we have Muslim culture, and woman, she it is she lived with her mother-in-law always. Yes, and mother-in-law is very strong woman, and she didn't give opportunity to our young woman to go to the doctor. And that is why we decided to change these barriers. We organized our team mobile bus, which goes to each village with huge team doctors, gynecologists, of course, social workers, and psychologists, and nurses, of course. And they can come to this, to home, to talk with that woman, to talk with mother-in-law, to talk with a young woman. And now it's during this year we changed, and we changed mentality of women, and they were glad to see doctors because they said maybe during them 10 years we haven't possibility to go to the doctors and to check the pulse. Okay. And about
genetic.
Genetic.
In this year, by the supporting of our Ministry of Health, we started our study on giving the access to study on BRCA mutation of the patient with ovarian cancer. So in this year, we started from studying BRCA mutation on serous ovarian cancer. We detected for this day, we detected over the 55 patients with ovarian cancer, and all of this is covered by state budget. It is free for patients, and in this work, in this study, AstraZeneca support us and give also the opportunity to provide this, more than 100 for more than 100 patients. So we hope that this diagnosis, BRCA testing, will be available for all patients. And so in the next step will be available state give the availability to provide PARP inhibitors for all patients with BRCA mutated ovarian cancer. So I think in support of the Ministry of Health and CASIOR, we decrease this barrier on the diagnosis of and treatment of ovarian cancer patients.
Yes, we changed all our protocols with ESMO and the WHO support, and include all drugs. And now our women have access to, of course, chemo, for target and immune if they need. Yes, and we hope that we will do change, and you said no woman left behind.
Thank you so much. Thank you.
Thank you.
So we had another question come up on WhatsApp, and Francis, if you can pop up on the screen, this one is for you. So Francis Reed is our director of programs, tireless director of programs, and Every Woman Study lead. So Francis, the question that came in was, how many women do you anticipate will participate in this study in total? And it's kind of a two-part question. It's also, why are you only recruiting from hospitals? Does that mean you will not reach women who are not in the system?
Okay, thank you. We aim to have a minimum sample size of around 2,100 women. We've tasked each country to come up with a minimum sample size based on the 5-year prevalence of ovarian cancer. So that is the number of women living within 5 years of their diagnosis, according to Globocan predictions. That allows those individual countries to be able to make some sort of statements themselves about care in their country, standalone, but it will also help us provide comparability between countries. We know some countries actually plan to collect much more data than that, and they can continue collecting data until the end of June 2023. And there are even discussions about individual countries continuing beyond that so that they can use this information as a live database. So why are we only collecting data on women in the hospitals? Because it's the most reliable way of actually finding women with ovarian cancer and reaching them in these settings. So in our original Every Woman study, we had 44 countries take part, and those did include some countries in lower middle income settings, but we were reaching out via patient organisations who were pan-cancer or via social media, and there's just no way we can reach those women. So the surefire way to go is via the hospitals. But yes, one of the big caveats of the study is that the data will record the experience of those women who make it as far as the hospitals. Many women don't, but it is a starting point. We can't measure what we can't see at the moment, but by learning more about the routes, about the barriers, we will hopefully be able to find out some really useful information. I mean, if I give you an example, I'm trying to remember off the top of my head now which country it is from one of the country interviews, but it was one of the African countries where, you know, treatments for ovarian cancer are free, but the diagnostic tests aren't. So that automatically means many people, many women don't pursue a diagnosis of ovarian cancer. So the numbers that we have, the projections that we have, they're the best that people can come up with at this point in time, but that the more we can begin to generate good information based on women's experience, and the more we understand about their experiences, then we'll be able to reach out further and wider. So I hope that answers that question.
Thank you so much, Frances. So Clara, the next one is for you. And it is, what is the call to action from the Access to Medicines Report in Every Woman Study? And I think with just a few minutes left, that's probably a good place to end.
Oh, okay,
Yeah.
that's fine. So
Yeah.
we have a simple call to action for the Access to Medicine and the Every Woman Study, and that is about making ovarian cancer a global priority. However, and we've heard here today, the barriers that women experience are quite profound and complex, and they can be anything from accessing basic information through to transport, through to healthcare systems that don't have the infrastructure or the resource to properly care for women. And we know all about these issues because we speak every day to clinicians and to patient advocates and to women. But what we don't have is the evidence, the data that we can use globally to lobby the World Health Organization and other agencies who are involved in cancer care to recognize ovarian cancer. What we don't have at country level, as I think has been so eloquently highlighted today, is the data that advocates and clinicians need to advocate their own governments and healthcare systems to do better for women with ovarian cancer. So it's a two-part answer. The call to action is that ovarian cancer has to be a global priority. And the way that we get there together as patient advocates, as clinicians, as women living with ovarian cancer is through collaboration and pulling that data set together. So that is our call to action. And Phaedra, I will hand back to you to thank everyone.
Yes, so thank you very much, everyone who came in person and who attended online. We will have the recording available later today, and the link to the recording will be emailed to all the registered participants, and we'll also pop it up on YouTube. Of course, you can reach out if you have any questions, even after the event. You can reach out to info@worldovariancancercoalition.org. And as we mentioned at the top of the event, we do have an electronic press kit that you can access, which has a whole bunch more background information, has the Access to Medicines report and some other information. So thank you so much, very much for joining us. And we look forward to getting to the world where no woman is left behind, where no woman is left behind. It's been a long morning. Okay, thank you so much. Bye.